Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. Millicent Rovelo, and I'm here with my very reflective, introspective co-host today, Dr. J. Calvert. How are you?
I am very introspective and reflective today. I don't know why.
I don't know why. We just finished our last podcast, and there were some deep, deep thoughts coming out of you. So, I don't know. You're feeling it.
I think what happens, there's a changing of the fellows at this point. Like, one of our fellows is going to the other rotation, and we're getting the fellow who started on the other rotation.
It's also a changing of the seasons.
It is a changing of the seasons. It's, it's one of those things where, you start to think, like, how can I be better? Like, how can I do better for the people that count on me? And that's a big thing for me. I want to be better. I want to be a better surgeon. I want to be a better man, a better dad, all those things. I just want to be better. So I want to be a better teacher for the fellows. And I was kind of thinking about it after hearing about, like, the interviews are starting. And we have people coming from, like, every part of the country to try to, interview for our fellowship because they want to get the spot here. And so I just think, I think about, like, how can I make this even better? If we're going to take our time to do it, it should be the best it can be.
It should be the best it can be. And so on that vein, we're talking about hard things that are hard to do. How do we teach people how to do these hard things? And what do our patients need to know about these hard operations? Our last one was one for you, cleft palates and cleft noses. The one for me, massive weight loss breasts.
And those are
They are really hard. But they are breasts, so they go well with champagne, which we're drinking tonight. So
they are really hard. They are. They're so difficult. There was a point back in the day when I was kind of training where they said, you don't do this. Like, it's just, you don't put implants, you can lift them, you could try something. Like, there was just, like, limited sort of approach to what to do with the massive weight loss breast problem.
And it's a problem. So these are patients who have lost large amounts of weight for whatever reason. Maybe it's from natural weight loss, diet, exercise. Maybe it's from a surgery where they had a gastric bypass, gastric sleeve, and they lost an excess of, 50, 60, 80, 100, 150 pounds. And the excess weight loss causes very loose skin. And aside from the fact that their skin is loose and things are saggy, the skin that's there is really poor quality skin. So I see this on my tummy tucks. I see it on the body lifts in these patients. I can pull these patients as tight as possible, and within a few months, things are loose again. They're not sagging so much, but they're just loose because that skin that's left behind is not good quality skin. It's like a rubber band that's lost, that's been pulled really tight, and it's been stretched past its capacity, and it never snaps back to the size it was before. That is the skin in these patients. And so a lot of times they present with volume deflation. They've lost the volume of breast tissue they used to have. That's a big one. And they have a lot of extra skin. So these breasts are literally looking at the ground. They're saying hi to their shoes. They are hanging out by their belly button, giving it high fives. Like, these are very long, stretchy, inelastic breasts.
And of course, the patient desire is to have them look amazing. Like, they want
it all. And usually and everyone's different, but usually they've already had their stomach done because that's the thing that really bothers them the most. So a lot of times they've already had a tummy tuck, and now they're moving on to the breasts. So they see the great results they got from the tummy tuck, and they can't leave their breasts, hanging out by their belly button anymore. So they're coming in to have the breasts lifted and rejuvenated. And now they're on that plastic surgery train. So yeah, they want them to look amazing.
Oh, yeah.
And sometimes they do come in with real problems, because the breasts are hanging down and sitting low. There's a lot of problems with sweat and rashes that can form under the breasts. So on rare occasions, insurance will cover a breast lift or a mastopexy. And all that does really is remove some extra skin and lift the nipple, lift the areola back up into a more rejuvenated appearance placement. It doesn't do a whole lot for the breast, though. I mean, really part of their problem is that they've lost volume. They've lost fat. They've lost breast tissue. And so by the time you've removed all the extra skin that's hanging way down and kind of put things back up into place, someone's gone from being a double D or a triple D breast to being like a B cup, because the majority of the volume that they were like stuffing into their breasts and bra cups was all extra skin. And once that skin is removed, there's very little left to actually make a breast mound.
Yeah, especially if they've lost weight. You know, this is the key, is that the weight loss part has caused, you know, the breast to deflate. The skin is thin. It's long, like you said, just these long tubes of they don't look awesome.
They don't. And the nipples tend to point inward. That's another thing that happens.
Yeah, they rotate.
They rotate inward. So usually, you know, breast nipples are kind of in the midline of the breast, looking forward. And in massive weight loss patients, they actually turn inward and are kind of looking at each other. As they say high five to the belly button.
They're not supposed to do that. I can tell you something about one patient I had who lost massive weight. He could actually put his breasts in his pockets. That's how long they were. He could actually put them in his pants pockets. Yeah, that's how long they were.
A whole new meaning to that little, what's that little ditty? Do your boobs hang low? Do they wobble to and fro? I think it's supposed to be about the ears, but then little boys turned it into boobs.
Yeah, of course. You know, that's
Can
predictable.
Can you throw them over your shoulder?
I just snorted. That's how funny that was. Yeah, so these long breasts, and I published a paper on how to do implants in massive weight loss patients, because I used to have all these patients, because I trained in Pittsburgh with Dennis Hurwitz, who was like the total body lift guy.
So let's talk about that real quick, because before we get to the implants, I want to talk about why implants.
Okay.
Because as you said, historically, we didn't put implants in patients because there were so many problems that came with implants.
Which were?
The main problem being that they don't stay where they're put. They tend to go out to the side. They tend to fall. Like we said, the skin itself is not great quality. So if you put in an implant, it tends to sag and fall out of position because the skin that's supporting it is not great quality skin. So the patients are constantly having revisions or just not having a good aesthetic outcome. So there used to be sort of a mantra that you don't put implants in a massive weight loss patient, or certainly not at the same time as a breast lift. But I think we realized going forward that a breast lift alone was not sufficient for these patients. Maybe it treated medical problems they were having, but it certainly did not give them a good-looking breast. So then we delved into putting implants into patients. But again, we had those problems. They kind of stretch out the skin, and you have problems with malposition, and they're going towards the armpits, and they're falling down again. So that brings us to solutions like you were just mentioning.
Well, and that was what I thought the problem was, which is why I did this lateral breast flap thing, was I thought that the inframammary fold was just obliterated.
Oh, it's gone.
Yeah. So that was where I was like, if you don't know where the breast is supposed to go on the trunk, how are you going to make a beautiful breast? Like you can't.
Usually these folds, so this is the IMF, we like talk about it all the time.
We have a whole podcast about inframammary fold reconstruction. The inframammary fold,
it's so important, especially important in implants surgery. And it's that fold that delineates the breast from the abdomen, and it's supposed to be an actual distinct fold. And in these massive weight loss patients, that fold has descended so low onto the abdomen, it's like almost by the belly button, and it's amorphous, it's not tight, it has no support to it. So yeah, you got to do something for it.
Yeah, and that's where I said since you had this long breast, you could take the skin from the side and deepithelialize it, take the external skin off, leave the deep skin, and bring it across the chest wall, sew it to the ribs, and, Bob's your uncle. You got yourself an inframammary fold, and it worked. And that's why we published it. And I think that started people to think like, hey, maybe we can do implants in these weight loss patients. And the answer is you can.
And you should.
But You gotta, just like all these problems we've been talking about, you have to analyze the situation and prepare for the problems that are going to come with doing what should be a routine operation in somebody that really can't have that operation. You have to upgrade the operation. You have to provide the, and this is where, surgical intensity is really key. You have to have that surgical intensity to say, I need to stabilize the lateral breast pocket. I need to stabilize the inframammary fold. I need to pick the right implant for this patient that isn't going to give the patient problems and me problems trying to take care of them. And so it's a big time analysis and planning session that will result in great results for you in these cases where great results are elusive.
Yeah, there's a lot that needs, there's a lot of moving parts for these. And I like the lateral breast flap. I've definitely done that. Sometimes I'll use some kind of mesh, like a Galaflex mesh, for additional soft tissue support. Because again, like we said, the skin sucks and it's going to stretch out. So the more sort of external, additional support structures we can give to those implants, the better that it'll stay in place. So I routinely lift and reinforce that IMF to the chest wall. I'm putting in the implants. I'm doing some kind of soft tissue support for the implants, whether it's mesh or the lateral breast flap, like you mentioned. And then you got to do the lift. You got to get the implants up and over the implant, put that nipple smack dab where you want it. That's the tricky part because it is a lot of skin that has to be removed. And you have like just tons of skin that now is a little bit even more challenging because you're trying to make it drape around this nice round implant in a really pretty way. Without the implant, you can remove the skin, put the nipple where it's supposed to be, and like whatever you're left with is like, hey, that's kind of what you got. But now when you have a beautiful round implant in there, trying to get all that extra skin to redrape around that pretty round implant, that can be challenging as well. So there's a lot of moving parts to this surgery.
And you typically need some volume.
And you need volume. This is where it's a little bit of a catch-22 because there is so much skin. Like I said, even when you remove everything that you can, there's still a lot of skin left behind, and you need a larger implant to inflate that skin. If you think about like a balloon, there's a small tight balloon, and there's a larger kind of inflated balloon. You need a lot more air into that larger balloon to even make a difference into the size of it. Same thing, you need a larger implant to fill out that extra skin. The problem with a larger implant is it ends up where you don't necessarily want it. It's heavy. It's going to stretch out that skin even more. So it's going to go into, a lower position, or it's going to go out to the sides, or it's going to stretch out, and now you're doing a revision. So this is why people don't put implants in, because they have problems.
You do, and you have a tremendous experience with these.
Because I think they need it. They need the implants, but they need to understand we're going to be back here sooner rather than later to take some more skin. And that's the deal. If the average person who's had a mastopexy augmentation or a lift with implants needs a touch-up or a revision every 10 to 15 years, these patients need a touch-up or revision every 2 to 5. And that seems really dramatic, but that's sort of the truth because that's how quickly their skin stretches out again. They're still going to look way better than they did when they started. But if they want to keep that lifted, rejuvenated breast, they're going to need to come back every 5 years or so and tighten up the skin a little bit more.
Yeah, I mean that's the bottom line. You got to understand that this is not a routine breast augmentation. It is so far from that, and it can be done well, and the results are great. I have a whole section on my website as well, they should go to your website actually because like you're doing a lot of this. I'm doing like my fitness models. Our patients are so different, and it's so funny because like the other day, like Dr. Orden's he walked through my waiting room, and I had my patients who are in the waiting room, and it was rhinoplasty patients and my fitness, breast augmentation and breast revision patients, and my youngish facelift patients, and Orden comes up to me and goes, "Excuse me, are all those women out there here to see you? These good-looking women that have come for operations to make them better?" I go, Drew, yeah, those are my patients. It's, it's Monday. This is when I see patients.
And if you ever heard Dr. Orden on TV, that's exactly what he sounds like.
And then he goes, how come everybody comes to see me 70 years old? What happened? Why do I get all the 70, 80-year-olds? I go, well, how old are you, Dr. Orden? He goes, that's not the point.
But it is.
We do tend to have patients that are our age.
Our age.
It's true.
Of similar personality, like gelling kind of thing. Like
it's true.
Plastic surgeons, maybe every surgeon, I'm not sure, but plastic surgeons for sure, we tend to attract, similar-ish patient profiles.
It's true. And, I was like, well, they're all kind of my age,
So Dr. Orden.
So yeah, that's who's, those, because that's what I keep saying is my patients have kind of gotten old with me.
Yeah.
And now they need facelifts. And so that's why I'm doing a lot of facelifts. But, it was really funny. And I mean, your patients are your age. It's really true.
It's really true,
if you look at who's on your schedule, it is very, like every once in a while you'll have somebody in their 50s or 60s, but most of your patients are 35 to 45 years old.
Yep.
And they come to you because you're their people. I mean, you don't have the same body issues that they do. You're not a massive weight loss. Wait, are you a massive weight loss patient?
I'm not a massive.
No, you're not. No. So otherwise, because good work if you are. But
who's your plastic surgeon?
That's right. Who did all that for you? But that's the thing is you wind up with patients that are your age, and they come to you because they feel like that kindred spirit, like you understand them, and it's
because we're in the same place in life.
Totally.
We talk about kids and schools and
right.
applications and all that stuff. And I had a patient actually the other day coming out of anesthesia. She's like, Dr. Rovelo, I'm so glad you're young and close to my age because you're going to be my plastic surgeon for the rest of my life.
It's true.
She already had 2 surgeries, maybe 3. So, yeah, she was in it.
It's true. I mean, that was, I remember the article very, very well from Sophia Loren where they said, they asked her, Miss Loren, how do you look so amazing? Like, what is it that's been your secret to your beauty? And she said, find a really good plastic surgeon and stay with them for your whole life.
God bless her. The honesty of the old days.
Totally. And she was just like, are you kidding me? Like, look at all this stuff I've done.
This was not alkaline water and a yoga retreat.
No, it's not. And she was really honest about it. And she did have a really great plastic surgeon. She looked great for her
whole life.
Her whole life. She's looked amazing. And there is something to that.
There's something to that.
Find your plastic surgeon and stay with them for your whole life.
So in my world, that tends to be the massive weight loss patients because there are a lot of areas that need work. So yes,
They're going to stay with you for life.
Yeah, they kind of are for life. And then they need the revisions like we just talked about. So the other thing we didn't address, the last thing we'll talk about on this subject, and you kind of mentioned it on your lateral breast flap, is that the extra skin of the breast is not just isolated to the breasts. It extends around the side of the chest. That's called the axilla or lateral chest wall. And usually it extends to the back as well, because obviously you have extra skin everywhere. It's not just in the front. So if you don't do something for that extra skin on the sides of the chest wall or on the sides of the breast or on the back, you're definitely going to have a subpar result, because you may have these beautiful breasts in the front and then you have these wings hanging off the side. So a lot of times this is combined with an upper body lift or a bra line lift. That's an incision that goes across the back where the bra line is. And everyone's screaming right now. But you got to understand in these weight loss patients, they're going to have incisions everywhere. There's no good way to get the extra skin out other than by cutting it out. But this is a beautiful surgery. We'll do a separate podcast on it later. It's hidden right where that bra or the bikini sits, and it gets all that extra skin in the back. It goes around and meets the incisions in the front where the breast incisions are and gets all that extra skin on the sides. And now you can really significantly narrow the width of their chest by removing that extra skin. So now their chest is nice and narrow, and then you can really see the projection of the implants and the breast.
And if you don't do it, they look like a linebacker.
They look like a linebacker. They may have beautiful breasts, but you can't really see them because the sides of the chest still are big and floppy.
Not cute.
You gotta do something. And sometimes I do it all at once. Sometimes I stage it. It just depends on how much skin we're dealing with, if we're doing the arms as well, things like that. But you're looking at a few surgeries. That's the bottom line. You're looking at a very complex surgery. It's going to cost more than a typical breast lift augmentation. The recovery is going to be a little more involved. And you're looking at earlier and more frequent revisions. Not because anything has gone wrong, but because it's just that's going to be the maintenance of them.
What is the cost of a lift and augmentation in a massive weight loss patient for you today, like range?
Probably 15 to 20,000. I think I'm probably on the lower end in Beverly Hills.
Yeah, for me, it's probably like 35 to 45,000.
Yeah.
Yeah, I think that's important for people to know. It's because it's not like a breast aug.
It's not like a breast aug. It's not like a breast lift, breast aug combination. It's a lot more. It's a lot more work. And that's just the breast alone. We're not even talking about like if we're doing upper body lifts and all that stuff. Yeah.
Cool. Well, I think we kind of covered that.
I think we got that.
That's good.
Yeah.
Is there anything else you want to add?
No, that's it. Happy Friday.
Why don't you take us out then?
This is the Beverly Hills Plastic Surgery Podcast coming to you from the 90210.